very lucid presentation. But as you have rightly put it, it's very much simplified. I've learned a lot. I think the viewers have know the excitement and when to declare, just can't be blabbering, and all those things you have brought in. Thank you so much for your very comprehensive, authoritative lecture on DST Simplified. Next, we are anxiously waiting for the next session by Dr. Leema Pauline, Seizure Mimics in Children. Dr. Leema Pauline is Professor of Pediatrics, Neurology in the Institute of Child Health and Hospital for Children. He's published several articles, both the national as well as international, and been an author for several books and contributed many chapters. His field of interest is pediatric stroke, demyelinating disorders, and inborn error of metabolism. And now she is here to tell us about seizure mimics in children. Over to Professor Dr. Leema Pauline. Dr. Leema Pauline?
Ma'am, you'll have to unmute yourself, ma'am.
Okay.
Yeah.
Am I able to now?
Yeah.
Sir, thank you very much for the nice introduction also, sir. And let me, after a hectic lecture, let me try to finish off as early as possible, sir. And the scope of my topic is to distinguish between seizures, true seizures and seizure mimics, and what are the various types of seizure mimics in different age groups. So we all know that paroxysmal events are common in children. And whenever a child is brought to our hospital with some abnormal movements, then we have to find out whether it is a true seizure or not. Whether that particular abnormal movement is a fit or a faint or a funny turn. And a large number of children who are diagnosed as epilepsy do not really have epilepsy. So it is our responsibility that we have to establish the diagnosis beyond doubt, because there is no question of trial anticonvulsants or trial anti-seizure medications. So how to distinguish between the two? It is purely clinical. Careful and detailed history taking is the cornerstone of an accurate diagnosis. The situation, not only the events that are occurred during the ictus, it is the situation or the context under which or at which the abnormal movements happen is more important and is critical. We have to ask a certain WHO questions like when did it happen? How did it happen? Where did it happen? So if the eyewitness is there, that either the parent or the grandparent, we can ask them to enact the event. Sometimes it may be accurate or sometimes it might be inaccurate as well. So if there is a home video, it will be of much help for us to distinguish whether it is a seizure or not. Even if there is a home video, it will show us only the ictal events, what happened during that event. Whereas the context and the situation after which or what happened previously, that is much more important to diagnose a seizure mimic. So the diagnosis is as good as history. We have different types of seizure mimics in different ages, and the newborn period, especially jitteriness and benign sleep myoclonus are the common ones. During infancy and toddler age group, breath holding spell, shuddering attack, stereotypies, Sandifer syndrome, self-gratification behavior, sleep disorders are common. During the older age group and adolescents, it's the syncope, pseudo-seizures, paroxysmal dyskinesias, periodic syndromes, and tics. So we will see certain common things which occur, which we come across in our day-to-day practice. During the neonatal period, we all know jitteriness is the commonest seizure mimic. Here, in jitteriness, the predominant movement is the tremor, and it is stimulus sensitive. And this movement ceases with flexion. When you restrain, when you hold that limb or that joint, then the movement ceases, it stops. And it is not associated with any gaze abnormality or autonomic changes. So this is how we have to distinguish jitteriness from a true seizure. And this jitteriness may be persistent. If it is persistent, then we have to rule out hypercalcemia as well as hypoglycemia as well. The second one is the benign sleep myoclonus. As the name refers, it is the predominantly myoclonic seizures which occur during sleep, and these are benign in nature. So this happens usually in the neurologically healthy neonates, both term and preterms, myoclonic jerks, little faster frequency, and they are not stopped with restraint. This is the feature which helps us to distinguish between a jittery child or a jitteriness and a benign sleep myoclonus. Usually, these movements are only during sleep, and it ceases. These movements ceases abruptly when the infant wakes up, and there are no neurological abnormalities either in the examination or in the outcome. This happens in the first 2 weeks of age, and they resolve by 3 months of age. And the most important clue is they never present during wakeful state. So only 2 questions we have to ask: whether it can be stopped by restraint. Then if it is stopped by restraint, it is jitteriness. If it is not, we have to consider benign neonatal, it is myoclonic jerks, and whether they are present during wakeful state. If they are present during wakeful state, then it is not benign sleep myoclonus. They will be never present during wakeful state. Usually the age is normal. The only thing is we have to explain to the parents about the benign nature. And coming to the infancy and toddler age group, breath-holding spells is the commonest type of seizure mimic we come across. Though we say it's benign, it can be, the episode can be frightening to the parents and to the caregivers or to the any observer who watches it. It's much more common in boys. Positive family history seen in 1/3 of the patients. Usual age group, age of onset is 6 to 18 months. After 2 years of age, the first episode occurs in only less than 10%. So the commonest age group is 6 to 18 months. The frequency varies from several spells a day to even once a year, but majority of the children have 1 to 6 episodes per week. Depending upon the color they develop during such episodes, it can be either a cyanotic spell or a pallid spell. In cyanotic spell, usually the kids are scolded or being denied something. They become angry, they become frustrated, they cry vigorously for less than 15 seconds, and they stop breath in expiration. Again, this is a misnomer. Here, they are not holding the breath in inspiration. They stop breath in expiration. Rapidly, they develop apnea with cyanosis. They lose their consciousness. They become limp. There may be brief clonic jerks, but recovery is within 1 minute. In pallid spell, usually the precipitating factors are a sudden fright or a pain, striking the head, or just hitting the head, or an IM injection. The child cries, loses its consciousness, becomes pale. Few clonic jerks may be present. Usually, it is associated with the bradycardia or asystole.
We are not able to hear.
Your slides aren't moving. I think there's loss of connectivity, sir.
I think we have lost her connectivity. She is not in the.
Yes, sir. I'm trying to reach out, sir.
Oh, okay. We'll see.
The madam is rejoining, sir.
Oh, okay, thank you.
Am I audible?
Yes,
Oh,
ma'am.
yes, ma'am.
Yes, ma'am.
So exact pathophysiological mechanisms for breath holding spells has not been elucidated. It is said that the autonomic dysfunction may be the main cause. There may be a cardiac inhibition through vagus nerve with the painful stimuli, or central inhibition of respiratory movements, even decreased sensitivity of the central nervous system to hypoxia and hypercapnia are the putative mechanisms. But the exact etiology is unclear. And so the main management is reassuring the parents. We should educate the parents to place the child in a lateral recumbent position to reduce the period of anoxia. And also we have to educate the parent that they should not provide second aid by picking up the child. It will be a natural act of the mother during the episodes. And it can reinforce the behavior. And if the child has any coexisting iron deficiency, iron supplements have to be given. Of late, people are telling, and there is literature, that iron supplements may be helpful even without anemia as well. Again, coming to the role of exact role of iron in breath holding spells is not known. Maybe the low hemoglobin level results in a reduced oxygenation to the brain is one of the considered mechanism. And again, iron can act as a cofactor for degrading enzymes of the cerebral catecholamines, and this can result in catecholamine disruption and subsequent autonomic dysregulation. And apart from iron, several other medications such as piracetam, levetiracetam are being used. Even theophylline has been used in breath holding spells, and atropine and glycopyrrolate, especially in palate spells, have been used with variable results. And in rare complicated cases, if there are severe recurrent spells associated with the severe bradycardia and cardiac asystole, ventricular pacemaker implantation has been considered as a therapeutic option. Now coming to the second scenario, a 2-year-old child is recently brought for repeated episodes of neck stiffening and shivering movements of shoulder and arms. These episodes last for 4 to 5 seconds and occur more than 10 times per day with no apparent pattern except increased frequency at meal time. Although there has been Rennie, என்ன நீ போச்சு? Although there has never been loss of consciousness, the parent was worried that these were seizures. So these are nothing but shuddering attacks, and these movements are stiffening or tonic posturing movement and rapid shivering movements of the head and upper limbs, at times involving the trunk. This can happen as early as 4 to 6 months of age. They typically last for few to 15 seconds, and again frequency varies widely, can be up to 100 times per day. During such episodes, the children or the infant is fully conscious throughout the episode and after an episode. Usual triggers can be excitement, eating, or frustration that is not being able to perform a task, and they do not occur during sleep. And various putative mechanisms are being described. Maybe this is an immature brain's expression of essential tremor, or it could be a variant of benign myoclonus of early infancy, and it could be a variant of motor tics, or simply it is a paroxysmal autonomic events similar to sneezing on or yawning, but nothing is evidence-based. So video tapping of the episodes is helpful. Usually the neurological examination is normal, the EEG is normal. If at all if it is done, it may show during the attack only a muscle artifact, and these episodes spontaneously decline in frequency and completely remit by 3 to 7 years of age. So parental education and reassurance are all that is needed. A single case report describes a trial of propranolol has been given with the success, but anti-epileptic medications are not effective and are not indicated. Next comes our familiar syndrome, that is the Sandifer syndrome, spasmodic torsional dystonia of chronic posturing associated with the gastroesophageal reflux disease. The clinical clue is typically the posturing occurs after feeding. So treatment for GERD alleviates the symptoms. Next, an 18-month-old toddler was brought by her mother with complaints of abnormal body movements of 2 months duration. Movements were described as stiffening with arcing of the back, rocking and twisting of the body with the scissoring of both the lower limbs with grunting, hyperventilation, and the child is said to be fully conscious and responds to call during such episodes, which last between 1 to 5 minutes. These episodes were stereotyped and the child had several episodes in a day. This is nothing but a self-gratification behavior, which is otherwise named as infantile masturbation. This happens, the commonest age group is 3 months to 3 years, and this is a normal behavioral variant seen in the early childhood. Usually the repetitive movements involve the lower trunk associated with pelvic thrusting. Both the thighs may adduct and rub against each other, and there may be vocalizations with grunting. There may be associated facial flushing. But the important clues are there is no alteration in consciousness, and there is a cessation with the distraction. If you just call the baby, the behavior stops or the movement stops. Or if you just lift the baby, the movement stops. So videotaping is invaluable, and reassuring the parents that it is a normal behavior in children. They will often outgrow it is the necessary thing. Scolding the child could result in positive reinforcement of such behavior, resulting in low self-esteem. So if the child is a little older child, we can gently talk to the child about the need to avoid such behaviors. The best thing will be engage the child in other play activities which could redirect their attention. Failure in recognition of such self-gratification behavior results in unnecessary investigations. Next is the sleep disorders. Usually these sleep disorders occur during that is NREM sleep, confusional arousal, night terror, even somnambulism can occur. In confusional arousal, these children, while sleeping, it occurs usually in the first few hours of sleep. They may sit up in the bed, moan. They may utter words like "no, no, go away," "I am afraid," "go away," like that. And usually lasts for a few minutes. They gradually go back to sleep with minimal autonomic. The autonomic symptoms will be minimal, like tachypnea, tachycardia, or perspiration will be minimal. Whereas in a night terror, the child is agitated, screams. It may moan, the child may moan, mumble, even sleepwalk. Marked autonomic features will be there. Excessive perspiration, tachycardia, tachypnea, all those things will be there. And these episodes, they stop abruptly and the child rapidly returns back to deep sleep. Typically, they do not arouse in full. They appear to recognize their parents and they do not remember in the morning anything. So there won't be any remembrance or they cannot recall. They are not aware of these things. These parasomnias, they go away on their own and often are harmless, requiring only reassurance. Coming to the older children, syncope is the commonest seizure mimic in older children and adolescents. Usually, it affects in the second decade. Girls are more commonly affected than the boys. The problem is here, it is nothing but a vasovagal reflex by which an emotional experience produces a peripheral pooling of blood, resulting in transient and diffuse cerebral hypoperfusion, leading on to temporary loss of consciousness and loss of postural tone. Usually there are premonitory symptoms such as lightheadedness, blurring of vision, muffled hearing, diaphoresis, pallor, and cold or clammy skin. These events are benign, they are self-limiting. It can be due to cardiac causes or non-cardiac causes. Cardiac syncope includes the various causes for cardiac syncope include sick sinus syndrome, WP syndrome, long QT interval syndrome, heart blocks, aortic stenosis, and HOSN. The clues are how to distinguish between a cardiac syncope and a neurocardiogenic syncope. In cardiac syncope, usually the syncope occurs abrupt onset and abrupt ALOC during exercise, and there won't be any premonitory symptoms. So when we are suspecting cardiac syncope, we have to go for prolonged ECG and Holter monitoring to rule out this arrhythmias. The other type of syncope is your neurocardiogenic syncope, commonly known as the vasovagal syncope. It usually occurs following an upright posture, prolonged standing, The children go for ALOC, but ALOC is very brief, few seconds to 1 to 2 minutes only. Many a times the children do not go for ALOC at all. They hear everything, and as the teacher or the caregivers or their friends coming near him, they are calling their name, they are sprinkling water on their faces. All those things they hear, but they may not be able to sit up, assume a upright position. There may be at times clonic posturing or 1 or 2 few clonic seizures, and there will be a rapid spontaneous recovery. The clues are in neurocardiogenic syncope, that is vasovagal syncope. It is of gradual onset. Premonitory symptoms like lightheadedness, blurring of vision will be present, and they are precipitated by prolonged standing and rapid recovery on assuming supine. These are the clues to distinguish between a cardiac and a neurocardiogenic syncope. In neurocardiogenic syncope, it's a simply vasovagal syncope. So EEG is not necessary. ECG may be necessary if it is recurrent or if it occurs with exercise to rule out long QT. The last one is the paroxysmal non-epileptic seizures, otherwise called the pseudo seizures. These are common in adolescents and in girls. It can occur in various forms and combinations. There may be convulsive movements, sudden slow limpness, or tonic posturing, or simply unresponsiveness. And the preferred terminology is paroxysmal non-epileptic seizures because this terminology is non-judgmental as well as more acceptable to parents rather than calling them as pseudo seizures. At times, it will be really difficult to distinguish a true seizure from a non-epileptic seizure, but the clinical clues are these movements are bizarre, they are rhythmic, they are coarsely clonic, and are associated with pelvic thrusting, whole body shaking, associated with hyperventilation. There won't be any incontinence, there won't be any self-injury, there won't be any tongue bite. And they have a tendency to occur in the presence of others to seek attention of others. And consciousness may appear to be impaired, but there is no real loss of consciousness at all. If you just try to open the eyelids of the child, there may be active resistance to eye opening. And these events are often prolonged and with a high frequency compared to true seizures. True seizures do not occur multiple times a day except absence probably and myoclonic seizures. Whereas in other types, you don't have everyday seizures, you don't have multiple episodes per day. So when whereas these paroxysmal non-epileptic seizures are prolonged as well as their frequency is high. And the most important point is the child will have the ability to reproduce the event and stop the event on command. That is, suggestibility test is positive. You can induce the seizures by suggestion. You can ask the child, yes, you are now, you just close your eyelid, just have a deep breath, do a deep breath, and you have to suggest, now it is coming, you are going to throw the seizures like that. The child will be able to reproduce the exact event. And when, okay, you can stop the event, then the child will stop the event. So inducible by suggestion in your day-to-day, in your clinic is the best method to identify the non-epileptic seizures. And still in doubt, we can do a video EEG, and the normal ictal pattern in the video EEG confirms the diagnosis. The most important thing is the psychosocial stress is more common in these children. Unless otherwise we do appropriate psychology and psychiatric consult, these children may develop another symptomatology. Maybe this time abnormal neurological movements, next time maybe a headache, next time maybe a stomach pain, so abdominal pain. So we will be again and again evaluating these children. So appropriate psychology and psychiatric consult is a must. So the take-home messages are distinguishing seizure mimics from true seizures is important to avoid unnecessary investigation to allay parents' anxiety. History is the most important thing, and home video, if available, it is invaluable. Normal video EEG confirms the diagnosis, and management is parental reassurance. Thank you very much for the patient hearing, and I apologize for the in-between technical snap. Thank you.
Thank you, Professor Leema, Pauline. Always, it's a very passionate to listen to you. Your message is always
I think we lost connectivity.
Yes, sir.
Can we ask Dr. Suman to start his presentation? Consultant from KKCTH, please start. Dr. Dakshayani, can you introduce Dr. Suman?
Am I audible, sir?
You are audible.
And is my screen visible?
Yes, screen visible.
Yeah, visible, sir.